prominent figures whose insights will set the tone for this inspiring gathering. So the FEMA president has just arrived. There, go. You're welcome. So in this digital era, we look forward to an exciting digital health panel exploring transformative developments in healthcare technology, including artificial intelligence and other cutting-edge innovations. Then we will have our annual general meeting in the afternoon, inshallah, and we're excited to have new officials join the Kammp fraternity. A memorable gala dinner is awaiting us this evening, a dinner that will provide an opportunity to connect, celebrate, and strengthen our bonds as a community and, inshallah, push Kammp to the next level. So this year's program is designed to inspire actionable solutions and foster collaboration among healthcare professionals while maintaining our commitment to ethics, innovation, and service to humanity. May Allah subhanahu wa ta'ala bless this conference with success, barakah, and benefit to all participants. May it serve as a means for personal and professional growth and contribute to improving the lives of those we serve. Amen. Shukran. And I was expecting to invite Dr. Iman, our conference chair, but I can't see him in the room. So maybe we can go ahead, yeah. And I will welcome our moderator for the session, Dr. Abdi Dabar. Just a minute, I find. Yeah, so Dr. Abdi Maalim is the immediate former commissioner of the Ethics and Anti-Corruption Commission and chaired the Commission's Committee on Corruption Prevention, Education, and Public Engagement. Between 2004 and 2013, he served as a presidential appointee to the National Anti-Corruption Campaign Steering Committee and chaired the Research and Advocacy Committee of the organization. He was also a member of the Transition Authority, which ushered in the devolved system of government in Kenya. Karibu, Dr. Dabar. And he is a nurse by profession. Take over. Start with
إن الحمد لله نحمده ونستعينه ونستغفره وأشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبده ورسوله. We thank Almighty Allah for bringing us together this morning again, for those of us who were yesterday. And we are looking for a brighter day, inshallah. As Sister Nabila has mentioned, we have very distinguished speakers who are going to take us through this morning. And inshallah, we'll start with the first one, Dr. F.K. Abdallah, one of our sisters, Dr. Abdallah. If I read all this, it will take a lot of time, but I will try my best. Dr. Abdallah is a retired senior lecturer and the thematic unit of hematology and the blood transfusion of the University of Nairobi, based at Kenyatta National Teaching and Referral Hospital, served as a unit head for 8 years. After teaching for 33 years, she left there. She represented the unit in several subcommittees and the committee members on the school master's board. Her research included both local and international, and has published in several peer-reviewed scientific journals and presented both national and international conferences in the field of hematology, oncology, and blood transfusion. She has held several positions with several professional societies, has organized local and international trainings, conferences, and was an editor of the East Africa Medical Journal. She she has been the head trainer and the senior technical advisor for Kenya National Blood Transfusion Service for the last 12 years with the University of Maryland, as well as for the Regional Society for Transfusion Kenya. Dr. Abdallah is a founder member of the East Africa, the EXA of pathologies, Hexagon pathologies or EXA. She served as a member of the board of directors for the Kenya Medical Dentists and Practitioners Board for 5 years and a member of the regional committee for East Africa. For the Madrasa program and early childhood program, which she also started, and also at the Kammp Foundation with this almost 10 years. She has been the director of the Africa Cancer Foundation and Resource Center for Women and Girls, as well as a trustee, and has worked there very many other places with as a physician on feasibility basis, what we call pro bono. Dr. Abdallah, please, welcome. These are very distinguished people, and we need to take their words. Let's take, and then also after the lecture, please spend time with them because we are very strict. I hope the timekeeper is taking as much as possible. Welcome.
Shukran. Shukran, Jazakallah khair. Oh, you didn't have to read all of that. Okay. It's okay, then I can read from here. See, I can read it from here. Is it charged? Yes, yes. It doesn't seem to be charging. It's okay. It's not charging? No, it's not charging, but it's okay. Since I can see it on this camera, it's fine. Okay, great. Yeah. Maybe look for a charger for me. Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillahirrahmanirrahim. Okay, so I've been given this task of discussing the code of professional conduct and medical ethics. I hope I'll be able to do justice to it, inshallah, with Allah's help, and with your contributions. Please feel free to interrupt in between, if I'm allowed, or do we leave for questions at the end? All right. Okay. Okay, so that's my scope. I have many slides, so I'll be rushing through some of them, and just so that I can keep to time. So the rationale is to provide guidance that promotes ethical professional behavior among practitioners regulated under Kammp 253 in the Kenyan laws, as well as the International Code of Medical Ethics that we're all supposed to subscribe to, and also to protect the public. Oh, the screen is gone. Okay. To uphold human dignity and ensure patient safety as well. So I think these fundamentals were discussed yesterday by Dr. Amin also, so I will not dwell on them. But just to go through respect for persons, beneficence, that means we should benefit the patient. Non-maleficence, we should not do any harm. Autonomy, we should allow patients to make their own informed choices. And also, they are entitled to protection from us, even if they don't know their rights. We know their rights and justice. So I'll dwell more on this, on now duties of the patient, duties of the practitioner to the patient. Yes, we said respect, we must respect patients and give them the dignity, autonomy, and the rights to freely accept or refuse care, even if we think we know better, but they have that right. We need to commit to the primacy of the patient's health and well-being and must offer care in the patient's best interests. We should strive to prevent or minimize harm for the patient, to be able to strike a balance. Even though we want to treat conditions, sometimes in treating the condition, we do more harm to the patient and alter their quality of life. and we should ensure accurate and timely medical documentation for our own sakes and for the sake of the rest of the profession. We should obtain the patient's voluntary informed consent prior to any medical care provided and in every phase of the process. And a patient who has limited or underdeveloped or impaired decision-making capacity should still be involved as much as possible in those decisions and with the help of the trusted representative or family member, except when the patient is in an emergency or the patient has come alone, as sometimes they are picked on the street. If any aspect of caring is beyond the capacity of a physician, we need to accept that, okay? And therefore we need to consult or refer to another appropriately qualified physician or health professional or to our seniors. We may be in the same field, but we have those who are more senior and more experienced than us. We should respect the patient's privacy and confidentiality even after death, except when disclosure is necessary to safeguard a significant and overriding ethical obligation, or if a physician acting on behalf of or reporting to any third parties. But it should be limited only to the minimum information necessary. We should refrain from intrusive or otherwise inappropriate advertising and marketing. And if it must be done, then we should ensure that all the information used is factual in that advertising and is not misleading to the observers. We should not allow commercial, financial, or other conflicting interests to affect the physician's professional judgment, even if it means that you may lose your job, but Allah will give you another one. After all, He's the provider, isn't it? So when providing care remotely, the physician must ensure that it is medically justifiable and that the necessary medical care is provided. But we should inform the patients the benefits and limitations of remote care. We should maintain appropriate professional boundaries between us and our patients, and we should provide care of the highest standards. But in order to do that, we also have to take care of ourselves. Our well-being, we must be healthy and be of sound ability. And if at any point we feel we are compromised, we should tell our superiors and excuse ourselves so that the patient may not suffer. And finally, for the patient, in the conscientious objection to provision of any medical interventions, the patient has a right to consult another qualified physician without disruption to care, and we should provide the necessary information without any objection when the patient needs to go there. So I thought I'd briefly mention and touch on conflict of interest. First of all, we should understand it's common, and it happens in a range of situations, and it's not always available, okay? But we need to sit back, think, and ask ourselves, what is our intention? Isn't it? So we should be concerned of the circumstances and find steps to mitigate those conflicts. There are also financial arrangements that affect practitioners' decisions. Unfortunately, in this world and in the current environment that we practice, and there are two types. One is the underservicing and over-servicing, okay? Over-servicing is overdoing treatment, overdoing investigations, overdoing prescriptions, polypharmacy. We give a patient a long prescription. Of course, they will not commit to it. And then underservicing is the failure to provide because maybe we feel the patient can't afford it or whatever other circumstances. Okay, and the second one is the practitioner-supplier-induced demand that exploits the patient's lack of knowledge. The patient doesn't have all the knowledge that we have, but we have it, okay? And therefore, we sometimes recommend interventions that the patient doesn't really require. But because of some undue pressures from different directions, we do this. We really have to try and avoid this as much as possible. Then we have duties towards each other, okay? As physicians and to all other health professionals. Remember, we work as a team, and alone we really can't take care of a patient. Therefore, we should engage with our colleagues in a respectful and collaborative manner without bias, harassment, or discriminatory conduct, even if they are our junior colleagues. We should respect our colleagues' patient-physician relationships. Maybe the patient was seen by another physician before, and not intervene unless we've been requested or we need to protect the patient from harm from the other physician. We need to have collegiality, okay? A big word. To respect each other, to support each other, to advise each other, and not to put down each other, especially not in front of patients, as we sometimes do, okay? We should not at all, even if you have information, we should protect each other. But between the patient, between us and the patient, this information shouldn't be told. You'd rather go directly to your colleague and tell them what you think they may not have done correctly and offer advice. Okay? We have a duty to train each other, especially our younger colleagues, to teach them, to coach them, to supervise, to guide and mentor them, so that the profession can continue, and therefore also selfishly for our own reasons, so that when we grow old and we need to be treated by fellow physicians, we will feel comfortable and trust that the younger colleagues that we taught, mentored, have the right qualifications and skills, so that you can sit back and let them take care of you, okay? In case there is a challenge, we should report to the appropriate authorities those conditions or circumstances which impede the physician or other health professionals from providing high standard care, whether this is through stress, abuse, poor working conditions. We shouldn't keep quiet, okay? Because we are human beings as well, and we also have rights as human beings. And our employers should not mistreat us just because we are always very understanding. Okay? We also have a duty to the health system and to our society. One is to contribute to the health and well-being of the populations they serve and society as a whole by giving health talks, for example, to support fair and equitable provision of health care, including addressing inequities in health, especially in the public service. We should be prudent in discussing new discoveries, technologies, or treatments in non-professional public settings, including social media, and we should ensure that the statements are scientifically correct and understandable. So we should use simple language and the language that the public can understand. We should support sound medical scientific research and share medical knowledge and expertise for the benefit of patients and advancement of care. We should hold ourselves and fellow physicians to the highest standards of professional conduct. And in case we see a colleague not behaving according to this, we can quietly pull them aside and advise them. We should provide help in emergencies while considering our own safety and competence. For example, in a bomb blast, make sure before you go in for help that you are well protected. Other duties of the health system that I won't dwell on are leadership, management and governance, patient safety and quality, prudent use of available healthcare resources. Responsibilities of practitioners in the communities are to have input in policies, to be an expert witness, maybe in court and elsewhere, to notify certain disease conditions, etc., etc. Then we also have a duty for the disability community, for mental health, not just for our patients, but for ourselves and our colleagues. We also need to be aware of gender-based violence and find a way of reporting it. And also it is our duty to protect children and the disabled and those with special needs. We also have a duty to the medical profession. One is to follow, protect, and promote ethical principles of the code. But we have several codes. There is the Kenyan Professional Conduct Code. There is the international one, and there are so many others of the World Medical Association. We should support fellow physicians in upholding responsibilities set out in the code and take measures to protect them from undue influence, abuse, exploitation, violence, or oppression from wherever they be coming from. We are the protectors of each other, okay? We should also engage in continuous learning throughout our professional life to maintain and develop our professional knowledge and skills. And therefore, the minimum CPD required of 50 points, we should really strive to do it. It is doable if we make a point of doing it. Another duty to the medical profession is that we all know that we work within healthcare systems that increasingly determine the models of healthcare delivery, reimbursements, mechanisms, and restrictions on referrals or use of services, the clinical practice guidelines, and limitations on benefit packages. All of this put the practitioner's independence and ability to uphold the professional standards at risk. So we need to be aware of this and point it out to each other. Then there's the regulatory body that has a role also in our profession. One is for registration and licensing for the sake of the patient and the society. Two, the regulatory bodies protect healthcare consumers from health risk. Three, they provide a safe working environment for healthcare professionals. And therefore, if we feel the environment in any facility isn't safe, we can report to them. And also they ensure, fourthly, that public health and welfare are served by health programs. There are emerging issues that we need to be aware of that bring in issues of medical ethics. Okay? One is blood transfusions. There are some communities that do not accept this, and that brings us sometimes into conflict of interest. Then there are emerging issues of cells, tissues, organ donations, and transplants, and we need input from our ulama. There are cosmetic interventions that are being done now. The issues of beginning of life, as well as end of life issues and euthanasia. The issues of assisted reproduction, and genetics, there's sports medicine and doping that's happening, and there's also e-health and telemedicine. Because of time, I couldn't go into details of these. So in summary, practitioners need to practice their profession with conscious honesty, integrity, and accountability. Even if nobody sees us, Allah sees us. Okay? While at the same time always exercising independent professional judgment so that you can be comfortable with yourself. Yesterday we were being asked, are you comfortable with yourself? Who are you? Secondly, we should not allow individual professional judgment, our own, to be influenced by the possibility of benefit, either to ourselves or to our institution. The conscience must be aware all the time. And lastly, we should collaborate with other physicians and health professionals who are involved in the care of our patients. And I think that brings me to the end. Those are my references. And I'd like to thank you, shukran, jazakallah khair, for listening to me and not interrupting, even though I allowed you to interrupt. Secondly, to Kammp for inviting me to give this presentation, and to all of you for listening very intently. So maybe now we have time for questions. I see we have a minute, 50 seconds.
Thank you. Thank you. I think let's get 2, 3 maybe questions before. How many minutes? Only 1 minute. Maybe 2 questions. 2 sisters kept to the time. This is a very important area, actually. Very, very important area of concern. And it's good that we ask our experts. Okay. That's great, yeah. Yes, actually there's a suggestion that we can listen to all the presenters and then we'll call them here and then we'll ask questions. That will be saving us time, isn't it? Thank you very much. Thank you, sister, for this wonderful presentation. We'll come back to you. Now, shukran. Our second speaker now is another sister, Sister Ridwan Aden Muhammad. Sister Ridwan is working with the head of Lions Diabetic Cancer Center, Care Center, sorry, Chief Medical Officer at the Boabab Circle, that's, I don't know what is, health tech startup in the UK. She's a member of the steering committee for non-communicable disease of WHO on girls and women and girls. I'm happy that our girls and mothers are taken care of. Welcome, sister.
Shukran. Thank you very much for the kind introduction, and to Kammp as well for organizing this wonderful conference, and I think to the organizing committee for asking me to speak today. So I have been tasked to speak about management of type 2 diabetes in patients who are trying to fast or who want to fast, who are intending to fast. We know that most of our patients, due to the spiritual factor, intend to fast. So we have to be able to manage these patients. I think Professor Abdallah, who is also my teacher, talked about ethical principles. We know the number one ethical principle is autonomy. So most of the time the patients insist on fasting, even if you tell them not to fast. So it's our duty to take them through that journey. And so I think once my slides come up, we could begin. And so hence the importance of this particular topic. Hence the importance of this particular topic, and we're not talking about the management of malaria in Ramadan or so and so forth. So, so I'll just start. So basically, there you go. Yeah, thank you. So basically, we are discussing management of type 2 diabetes during Ramadan. And so a disclaimer there, this talk is sponsored by Novartis. And So my outline will be the pre-Ramadan assessments, the education, and the medical management or other adjustments that we try to do for this patient right before Ramadan. And so I've been given just 20 minutes, so I'm just highlighting this. So for those of you who are interested in the topic, Diabetes in Ramadan Practical Guidelines of 2021 is quite comprehensive. You can go back to it. It's free and you can find it online. And so we're discussing these patients because of the risks associated with fasting in our type 2 diabetes patients. And the major risks we have are hypoglycemia, obviously because we are fasting from dusk to dawn, so there is reduced calorific intake, and most of our patients are still on their anti-glycemic medications. Most of our patients don't visit their clinics to try and manage themselves, so they'll still continue with their medications, which are trying to reduce the sugars and reduce calorific intake, and so there's the risk of hypoglycemia. Then we have on the other spectrum hyperglycemia, where you have high sugars. And why do they have high sugars? Because when you're fasting, your metabolism shifts to the glycogenolysis. So your glycogen is being broken down to produce sugar. You have gluconeogenesis. Other substrates are coming in to try and produce sugar. And then you have the patients who know that these medicines that they take reduce sugar. So what do? They reduce their medication. And so what happens? Their sugars go up because of all these factors. And then we have dehydration, reduced fluid intake. And then we know most of our patients who are Muslims stay in places where the temperatures are quite high, so they already are predisposed to being dehydrated. And then I'll come to discuss, we have some medications we use in diabetes which tend to cause dehydration. So we need to look at this. And obviously with dehydration, we have also risk of thrombosis in these patients. Remember, type 2 diabetes in itself is a pro-inflammatory, pro-thrombotic state. And then you introduce this as well, or this comes on top of it, you tend to get thrombosis. And then you have ketoacidosis. Ketoacidosis, obviously we all know the type 1 diabetes patients are highly predisposed to it because they will not be taking their insulin because of risk of hypoglycemia, and their sugars might be going up, and so they can go into ketoacidosis. Ketoacidosis does not only occur in type 1 diabetes, even our type 2 diabetes who are insulin deficient can go into ketoacidosis. So we need to look out for that. So these are the risks that our patients face, and hence we need to look out for and we need to educate them. And so the targets for Ramadan diabetes focused education should not be only you, the healthcare professionals, but we strive to have it in the communities as well for our patients. The religious leaders as well have to be informed about this. So by any chance, even if it means virtually, we need to have this happening for our patients. So I'll try and take you through this using a patient case scenario. So I'll introduce Ahmed, who is a 55-year-old man with type 2 diabetes. For 5 years, he's an accountant. He is on glibenclamide and metformin, like most of our patients are, and he experiences blood sugar fluctuations and has had 2 instances of hypoglycemia in the previous Ramadan. Despite his efforts to adjust, he gets caught up in between the fasting and the need to stabilize his blood sugar. His HbA1c at that time is 7.8, and he does not consistently monitor his sugar levels. So how do we go about this patient? So this is your typical patient in your clinic. This is almost every other day you see this patient in your clinic. So how do we usually go about this? Like any patient, you have your medical history, and so you go through the history of the patient with the medication, with if there are any complications, comorbidities, if the patient is able to self-manage themselves, check their blood sugars at home, if they have increasing risk of, if there is any increased risk of him fasting or not fasting. So how do we do this? We have a risk stratification tool that we use, and this was developed by the Diabetes and Ramadan in partnership with IDF, International Diabetes Federation. The tool is standardized and we use it. It's used across the world actually, so you can find it again online for free. I usually in the clinic, when we have these patients coming in, we print it and we just have it aside and we do it for every patient. So it's quite easy to do, and we will go through it right now. So you have to discuss the role of self-monitoring of blood glucose, when to break the fast, when to exercise, what to eat and how to eat, and definitely we have to do the medication adjustments for this patient. And so I'll take you through each, and we'll start with the risk quantification. And so we'll use the use case, our patient Ahmad in this case. So if you look at the risk stratification tool, this is how it looks. So you have the type of diabetes which you get from your history, obviously, for the patient. And for our patient Ahmad, you can see there he has type 2 diabetes, so he scores 0. You can see type 1 diabetes has 1. So type 1 diabetes, in the case of Ramadan and fasting, these patients have a high risk. So the duration of diabetes matters, because the longer you have diabetes, the progression of the condition has occurred. So this patient poses a higher risk for fasting as compared to a patient who's been diagnosed for less than 10 years, in our case Ahmed, who scores a 0 there. And then presence of hypoglycemia. Remember, hypoglycemia is a high risk for our patients who are living with diabetes and they're trying to fast. So this is a very important factor to check. And patients with hypoglycemia and awareness score the highest there with 6.5. Our patient usually has, because of the fatigue, because of the medication he's on, reported hypoglycemia less than 1 time a week, so he scores a 1 there. And the type of treatments, obviously the medications that tend to cause hypoglycemia tend to score the highest in the risk tool. And so glibenclamide, which our patient is on, the patient scores 1 there. And level of glycemic control. Our patient's HbA1c was 7.8%. Patients with who have HbA1c of less than 7.5% usually tend to score 0, but our patient there scores 1 because he falls between 7.5 and 9%. Macrovascular complications, our patient did not have that. Renal complication, as you can see, depending on the EGFR. So remember, you have to do your estimated glomerular filtration rate for your patient. So you have to check the creatinine for your patient and try so that you can risk stratify your patient. You have to ask for the acute complications, whether they've had any of the acute complications in the past 1 year. And self-monitoring of blood glucose is very important. This determines to us whether this patient can self-manage themselves or take care of themselves, can identify these risks that we mentioned, whether they can identify it at home. And one of the way we assess or monitor this is through their ability to self-monitor themselves. And our patient could monitor himself, but he was not doing it optimally like he should. So he scores a 1 there. He's not frail, he's 55 years old, so no cognitive impairment as well. His physical labor, he's an accountant. No offense to accountants, but mostly like us, they just sit behind the desk and probably just try and balance their books. So I don't think he was in any form of intense labor, and he did not have any plan for, he does not usually have any physical activity. Basically, he was just sedentary. Previous Ramadan experience, he's had 2 episodes of hypoglycemia in the past Ramadan, so his overall negative experience and scores a 1 there. Fasting hours, this is because this tool is used all over the world because of the summer-winter timings in the northern hemisphere and southern, so you tend to have that. And for us, at least, we're around the equator, so we always score our patients 0 there. And the pregnancy is for the female patient. So my patient was a male and did not need to have any risk score there. So what is the current level risk for this patient for fasting? How many of you think he's high risk? By show of hands, how many think he's high risk? Nobody. Okay. Moderate risk? Okay. It's a few there. Low risk? How many of you think he's low risk? Okay. Quite attentive, I see. So this is the risk level of recommendation, and our patient scored 5. As you can see there, 3.5 to 6 is actually moderate risk. Patients who score less than, between 0 to 3 are low risk, and patients who score above 6 are categorized as high risk. So our patient here, we categorized him at moderate risk. And so what does this mean? It means that our patient needs to be evaluated. His medications need to be adjusted, and he needs strict monitoring. And so a caveat here is that most of our patients, a lot of them tend to have type 2 diabetes more than 10 years, have had some sort of complications, and so they tend to score at a risk of 6. And they're functioning highly at their capacity, at their level, and so we tell them we don't advise you to fast, and they feel like they're capable of fasting. we go back to the ethical principles again, autonomy. These patients insist still on fasting. So what do? You can't do anything. You let them fast. But what do? You follow them carefully. You evaluate them. You adjust their medication, and you strictly monitor them and follow them. So there are patients who can fall in the high-risk category but insist on fasting, which you are supposed to guide them. And how do we go about that? So how do we tell them about monitoring? So our patient, Ahmed, so our patient does not usually monitor optimally. So we need to discuss this with him. He has a medication which has high risk of hypoglycemia, which is glibenclamide, long duration of action, and can go into hypoglycemia. So we need to discuss about the 7-point guide for Ramadan. So when monitoring, we do the pre-suhoor, we check the sugar, mid-morning, at noon, and then mid-afternoon. Most importantly, the sugar that you should not miss is actually the pre-iftar, because you need to know if this patient has high risk of hypoglycemia, and that is the time they tend to go into hypoglycemia, just between after Asr going towards iftar. And then obviously 2 hours after iftar, you need to check the postprandial glycemia so that you know. And at any particular point when the patient feels that they're not okay, they need to monitor their sugars. And then you have to, we'll come to it, the hypoglycemia, when to break the fast, so that even then they need to check at any particular point where they feel they're not okay. So what does this do for our patient? It enables them to self-manage themselves and have the confidence to go through Ramadan. They can't come see you every day, so it gives that confidence. And so when we talk about the levels of sugars of when to break the fast, for hypoglycemia, the alert level is if a patient reaches 3.9 millimoles, the patient has to break the fast. And for hyperglycemia at 16.6 millimoles, they have to break the fast. Or any symptoms of, if they feel any particular symptoms of acute illness, they are allowed to break the fast, as that can be an exemption for fasting anyway. So when we come to fluid and dietary advice, I think you had a great workshop yesterday on nutrition. And so for this, usually our patients, our nutritionists in the clinic take care of it. But just to highlight, the diet is very important for these patients. I know we have very nice delicacies when it comes to Ramadan, but that has to stop. We just need to eat a usual meal. We don't need to feast, but we just need to have a normal meal for our type 2 diabetes patients especially, but I suggest for all of us. So for the carbohydrates, we tend to take about 45 to 50%. Another caveat there again is this depends on your expenditure, your energy expenditure. Your calorie intake should be able to balance with what you're outputting. So if you're sedentary, you don't really need to have so much carbs, but if it's somebody who is a construction worker, whose daily activities involves a lot of energy, they probably need to have more than the others. In short, what I'm trying to say is this is highly individualized. Just like the medication that we use for our patients, nutritional meal plans are also highly individualized. And for proteins, we advise up to 30%. Some people advise up to 50%, depending again on the conditions. And remember, for your comorbid patients, which we advise obviously not to fast, like the patients in CKD, whose protein intake is also limited again. Fluids, we need to talk about fluids with our patient. Between iftar and suhoor, they need to take as much fluids as possible, at least if, depending on the area, again, you're in the temperature levels and some medications which we will come to discuss. When we talk about fruits and vegetables, again, remember some fruits have high sugar content, so the nutritionist should be able to advise on that. What I need to say is avoid sweetened beverages and caffeinated drinks as well. That could also lead to the dehydration that we were talking about. So complex carbohydrates are advised at suhoor because these actually tend to release your sugars slowly throughout the day as compared to the simple carbohydrates, which they could take during iftar because it tends to shift the sugars, take the sugars quite up quickly. And so we come to physical activity. Physical activity, avoid rigorous activity towards iftar because now you'll tend to have the patients going into hypoglycemia and risk dehydration. Just to note that the normal Taraweh prayers that we have are actually quite a form of exercise, and it has been noted that the more night prayers that you do, the HbA1c and there is also reduction in HbA1c control and reduction in body weight. So when to break the fast, I think we've discussed that. The alert levels we've discussed. The symptoms of hypoglycemia and hyperglycemia we need to discuss. I need to mention that patients who have nausea, vomiting, abdominal pain, know these patients are going into DKA, and these patients really need to break their fast. For the hypoglycemia level, please don't, hypoglycemia symptoms, don't wait for them to get to the neuroglycopenic symptoms of coma, confusion. Please advise them to break the fast as soon as they start getting the hunger and the trembling and the sweating. So we usually advise our patients to do trial fast, at least 3 consecutive days. And this usually we use the 3 white days, especially during Shaban or Rajab, so that we can prepare them, for them to get the feel of how it will be. And this we do when we've given them the education with the adjustment of medication, so that we see where the points are, where we need to improve on are. And so now we come to medication adjustment. So for type 2 diabetes, we have quite an armamentarium in terms of managing our patients. We have the oral glucose lowering agents, we have all the insulins that we can use, we have the new injectable GLP-1 receptor agonists that we can use for all these patients. So none of them is exempt. When we talk about our wonder drug, metformin, metformin does not have a side effect of hypoglycemia. So there is no dose adjustment for this, except for those patients you're giving 3 times a day, probably the lunch dose to be combined with the iftar dose. Then come to the DPP-4 inhibitors. DPP-4 inhibitors, even in the non-fasting patients, does not cause hypoglycemia. And meta-analysis done of so many randomized control trials have also shown that they have very low incidence of causing hypoglycemia, even as compared to the sulfonylureas. And these are all studies which were done with the DPP-4 inhibitor, vildagliptin, and it showed that there are less hypoglycemic events, even as compared to the sulfonylureas. So coming back to our patient again, Ahmad, who was on glibenclamide, we had to stop the glibenclamide because it has higher chances of causing hypoglycemia, and we had to switch it to vildagliptin for him to get less hypoglycemia, and it has benefit of improved HbA1c, as well as it's very easy to adhere to for our patients. So you can see there, the vector study showed that. Sulfonylureas, potential to cause hypoglycemia. So for the ones taking once a day, it's taken at iftar. But again, for patients who are very well controlled, we need to half the dose. But for patients who are not well controlled, maintain the dose if you're giving it once a day. We usually give it in the morning, but we shift it to iftar. For those who are taking twice a day, we half the dose for suhoor and give the normal dose for iftar. Again, for patients who are very well controlled, this is a drug we may consider halving the dose completely. Avoid using the older SUs like the glibenclamide. The newer generation SUs like the gliclazide are preferred. SGLT2 inhibitors, a very low risk of causing hypoglycemia. Remember, this is a drug we use in our kidney patients who do not have, CKD patients who do not have diabetes, our heart failure patients who do not have diabetes. The potential for hypoglycemia is not that much. However, if you're using it together with insulin and sulfonylureas, you really need to reduce the dosages of those drugs because you can get a hypoglycemia. It causes dehydration as well. This is a drug which you need to tell your patients to take adequate fluids, and you can avoid it in the case of all the cases that under normal circumstances we tend to avoid. In acute illness, surgery, we need to avoid. And so that increasing fluid intake that I've mentioned. So GLP-1 analogs, we tend to use them. For the SGLT2 inhibitors, GLP-1 analogs, please do not initiate it during Ramadan, at least a month or 2 weeks before Ramadan, so that you see how the patient reacts to it, because GLP-1 also has adverse effects associated with the gastrointestinal system, but it does not need dose modification. So insulin. So insulin causes hypoglycemia, especially the complex insulin regimen, so we need to watch out for that. It is, you can use it in Ramadan, the subcutaneous, IV, and IM, but it needs a lot of education around it, and we have patients on insulin who are fasting if they are very well educated. So basal bolus regimen. For the basal, I know a lot of our type 2 diabetes patients are using combination basal insulin with orals. So for the basal, you need to maintain it to evening, the Lantus, the NPH, the Levemir, but you need to reduce the dose by up to 30%. If the patient is using boluses with it before each meal, obviously the lunch dose is omitted. For the morning suhoor dose, you have to reduce it to 50%, but for the iftar dose, you maintain it. The complex one comes to the premix insulins, especially the ones we have in the market, where you have the low ratio premix, the 30-70, the Novomix and the Mixtads. So the disadvantage with this is the bolus part is actually quite small, and people tend to feast when it comes to Ramadan. So you tend to have postprandial hyperglycemia, and then you have the NPH, which comes in later on to peaks and causes hypoglycemia. So for this patient, a lot of times, for me, I prefer to switch them back to the basal bolus, but if they insist on it, we tend to put them on at least the higher mix, which is the 50-50, like the Humalog, which we have in the market. That is the one we do, or we switch them to GLP-1s for those who can afford, together with their basal insulin. So premix, again, premix usually is 2/3 dose in the morning and a 1/3 dose in the evening. So we switch the 2/3 goes in the evening and the 1/3 in the morning. But for the morning, you have to reduce it by 50%, and for the evening, you reduce it by about 30%. So our take-home message is structured diabetes education is a multidisciplinary team. So we can't do this without our dietitians. We can't do this without our diabetes educator. If you decide to sit there with your patient to do the education for insulin, it will take almost half your day. So you need the educators to help you do this. So I'm emphasizing diabetes education when it comes to Ramadan and type 2 diabetes. So the risk assessment is quite important. We've gone through it. It's very easy. It just takes a few minutes because all those components are from your history. So you just need to tick and add it up and risk stratify your patient, because there are those patients who absolutely we try and contraindicate them from fasting. So pre-Ramadan use of trial fast is important. Oral medication and insulin, all of them can be used safely in Ramadan with appropriate dose adjustments and titrations in selected patients. And like all other patients who have type 2 diabetes, even for our fasting patients, we try to individualize all the components of therapy, including nutrition. So I would like to welcome you 2 weeks from now, 30th of November, to our Diabetes and Ramadan Africa. So we have DAR Africa, which we are part of as diabetologists in Kenya, our Muslim diabetologists. We have a workshop. We have speakers coming from UAE and the rest of Africa. It will be happening on 30th of November, and we are in partnership with Kammp as well, and it will be happening at the Pan-Africa Hotel. So it's a whole day of diabetes and Ramadan, which I was just given 20 minutes to discuss. So you can come and learn more, inshallah. Shukran.
Thank you very much, Sister Ridwan. That was wonderful, really. Before I call the second speaker, let me introduce our brother, for your attention, Dr. Abdi Mohammed from Shah. I'm sure he's very much required here, and thank you very much for coming to support the workshop. Now I'll call the next speaker, who is Dr. Yaqub. Dr. Yaqub is a critical care pharmacist with masters in pharmaceutical clinical pharmacy from Nairobi University. Has previously served at Kammp as one of the national members. He also chaired the Northeastern branch of Kammp, and has also served the chairman of the Pharmaceutical Society of Kenya, Coast Branch. Karibu, Daktari.
Mi simsijui jamani.
Okay, work-life balance. Three circles. How many hours do we advise our patients to sleep now? Someone is saying 16. Okay. 8 hours, right? The average person works for how many hours? 8, right? 10. The average. I know we are not average, right? But let's go with the average for now. So we are left with 8 hours to do every other thing, right? Now, the question we need to ask ourselves is, how much of each other ball is taking time from the other? Do we really sleep 8 hours? We hardly get to 6, right? And work hours take some time from the others. Now, this ball that is 8 hours that I haven't really labeled, you may find that it's the most important one. True or false? 8 hours to do other things. If I may actually go back to yesterday, Dr. Azra asked us to leave our CVs outside the door. Today I want you to bring them back in. Because the truth is you cannot really separate yourself from responsibilities. Yeah? So, as you wear all these hats, then how do you balance your life? And actually nowadays we don't talk about work-life balance. We try to ask ourselves, how can we integrate it between work and life? Now, I want us to draw 5 other circles. Just under the 3 that we did. As we finish that, anyone can volunteer to tell me what was the theme for this year's World Mental Health Day? And what did you do about it at your place of giving leakage action? What was the theme? Anyone? It is not safety at work. But good try. Yes, it is time to prioritize mental health at the workplace. The average person again spends a third of your life, average adult actually, a third of your life at work. And if you see from the first 3 circles, a third of your time every day is spent where? At work. So it's going to significantly affect who you are when you go back home, who you are when you go to interact with your social networks. So it is actually time to do that prioritization. And in the morning, I like the first speaker who talked about who are we at work. Are you the toxic person? Or are you the one who is actually making life easier for junior colleagues, so to speak? Now, the 5 goals that we've just drawn, one of them has to be work, yes? Now, which are the other important goals in your life? The other things you juggle? Coach Koreshi, back to you. Work, we've said that one is a given. Which other one? Work and work again. You can put it as 2 circles if you choose to. 2 Yes, we can hear you. Please go on.
Assalamu alaikum warahmatullahi wabarakatuh. Thank you very much for having your vote today. I'm going to talk about the miracle of the Deen, the Quran. And before I start my presentation, I just want us to understand the production of honey and the medicinal use of honey, and the understanding that honey production was discovered since late time before around this. So the understanding that honey production in a specialized part of the body of the bee and its digestive system dates back centuries, became more scientifically accurate in the 17th and 18th century. And earlier texts such as those of Aristotle's writings dating back 4th century BC describe the bees collecting the nectar, but the role of the bees' digestive system was not understood. In the 17th century, there was a Dutch scientist by the name Jan Sommerda, and this particular scientist was really involved in the study of the bee, bees anatomy. He dissected bees and he described the bees' internal structures, the stomach, the parts of the digestive system, and he described the honey stomach. One of the names he called it a crop. Crop is one of the stomach of the honeybee. And then in the 18th and 19th century is when naturalists and entomologists confirmed that bees actually collect nectar, they store it in their honey stomach, and they use enzymes to transform the honey during vegetation and evaporation. So I want us to go back to the Quran and see what the Quran mentions about the bees and the honey making process. So this is a verse from Surah Al-Nahl, chapter 16 of the Quran, verse 68 and 69, and it mentions that Allah subhanahu wa ta'ala inspires the bees, and He inspires the bees to make their homes in the mountains and the trees, and in what people construct, and then He instructs the bees to feed from the flowers of the fruit, of any fruit, as the bees. And they follow the ways of the Lord, which Allah has made them easy for them. And from its belly, from the belly of the bee, comes a liquid of varying colors in which there is a healing for people. And the verse ends by mentioning that surely this is a sign for those who neglect. So we are going to focus on this ayah, the second ayah, which mentions ثم كلي من كل الثمرات فاسلكي سبل ربك ذللا. So for those who understand Arabic, first of all, you can look at the beginning of the ayah. Allah will say, أوحى ربك إلى النحل أن اتخذي. So this year there, which I've circled, shows that this particular pronoun goes back to show that this particular insect is a female insect. It doesn't mention النحل and النخل من الجبال. So this here shows that this particular insect is a female insect. And then it mentions ثم كلي. Allah Allah instructs this particular female bee to eat from these particular fruits, flowers of any of these fruits, and then he instructs this particular bee to follow the way. And then Allah subhanahu wa ta'ala mentions that يَخْرُجُ مِنْ بُطُونِهَا. So if you look at this particular part of this verse, and look at it very carefully, it says here يَخْرُجُ. يَخْرُجُ means it comes out, right? Comes forth. مِنْ بُطُونِهَا. Butun here is jam'u of button. Butun is jam'u of button. It is the plural of the word button. Button is stomach in English. It is translated as stomach. But butun means many stomachs. But if you look at butun, this is a noun interlinked with a pronoun here, ha. And this ha, in the Arabic language, it's called ضمير المتصلة الغائبة. So it goes back to just a single bee. So it shows here that this particular insect has many stomachs within its belly. And this is the secret which we're going to reveal here. This is a miracle of the Quran. And then Allah mentions that يَخْرُجُ مِنْ بُطُونِهَا. It comes forth from these stomachs of this one single insect, one single bee, sharab, a liquid. It doesn't mention here that this is honey. It doesn't mention asal. It mentions that this is a drink, a liquid, of which mukhtalifun alwan. It is of varying colors. So we're going to see the varying colors of this particular liquid. And then fihi shifa'un linnas. Allah subhanahu wa ta'ala mentions that within it is which there's a healing for people. And then it ends by saying, إِنَّ فِي ذَلِكَ لَآيَةً لِقَوْمٍ يَتَفَكَّرُونَ. So surely this is a sign for those people who are going to reflect. Here it mentions, all this, يَخْرُجُ, this is فعل مضارع. And يَتَفَكَّرُونَ, this is also فعل مضارع. So let's look at the linguistic part of it. يَخْرُجُ مِنْ بُطُونِهَا شَرَابٌ. So here is the mention of butun. Butun, its bellies. It goes back to a one single bee, which describes the honey as a product of coming from a female bee's body. And then this points to a sophisticated process rather than honey being derived from flowers. And then the scientific miracle here, it aligns to the scientific process where the bees gather the nectar and convert it into honey through enzymatic activity in the stomach, and then in these stomachs, and it deposits it in the honeycombs. And then the choice of the words here, it is very intricate. The details are very intricate, all right? And it describes a process occurring within the bees. So this was unknown during the time of the revelation of this particular verse. So this is a dissection of the bee, and here we can appreciate that from the esophagus here we can see we have a pharynx, and then we have the esophagus, and then we have something called a crop. So we have a crop ventriculus. This is the crop is the first part of the stomach where the nectar is stored, and then there's enzymatic activity, and then it goes to a second part, which is the midgut, and then it goes towards the hindgut or the ileum. And then it goes, we have the rectum of the bee. But we're going to focus on this, the foregut and the midgut here. So, if you look at this is the section of the bee, and it clearly shows the different parts of the stomach. We have the esophagus, the crop here, and then we have proventriculus, and then we have something called a ventriculus, all this part of the stomach of the bee, and then we have some tubules, and we have the ileum. So I'm going to take you to explain to you the process of the bee, how the bee makes the honey. So we have what we call a worker bee, or a forager bee, which goes out and looks for forages for nectar from different flowers. And it takes up this nectar using its proboscis, and then once it takes up the nectar, there's partial digestion in the honey stomach, or what we call the crop. And here there's an enzyme called invertase, which begins breaking down sugars which are found in this particular nectar to simpler sugars, into glucose and fructose. So we have sucrose being broken down to glucose and sucrose, glucose and fructose. Then this particular bee goes back to the hive, and there's actual transfer of this particular product. So this particular bee is going to regurgitate this particular product, these sugars, to another bee, and this second bee continues the enzymatic processing, adding another enzyme in the second part of the stomach now, or what we call the proventriculus and in the ventriculus here. So it releases glucose oxidase, which produces gluconic acid and hydrogen peroxide. And we are going to see the importance of this hydrogen peroxide here, because this is a preservative which is essential for the preservation of the honey in the honeycomb of the bee. And then after that is when this particular bee, which is in the hive, the worker bee, actually regurgitates whatever has been produced, has been processed, and then it deposits this particular liquid. When at this particular point, it has not been made into honey yet. So it's still in a liquid form, and then it deposits the liquid, the nectar, which has been partially digested, into the honeycomb cells, and then these bees start fanning this particular liquid. So they fan it very vigorously with their wings, and it increases airflow, and there's evaporation of water from the nectar. So this is part of the ripening and of the honey. And the nectar, which has been digested, starts to cool down and starts to crystallize. It starts to transform. It transforms into honey. It becomes thick and becomes more viscous. And then once it is fully ripened, that's when the bees seal the honeycomb. So here you can appreciate the bee here on this the right side of my presentation. A bee regurgitating this particular liquid which has been digested, and then it inserts this particular liquid, and then after that it seals that particular part of the honeycomb. And then, so that's where storage happens. So the sealed honey serves as a long-term energy source for the colony. Then Allah subhanahu wa ta'ala mentions here that mukhtalifun alwan, it comes in different colors. So scientists here have discovered that there are several different types of colors of honey, from water white, extra white, to extra light amber, up to dark amber. And the color of honey is actually determined by the source of the food the bees take. So the different types of flowers, the different types of nectar, the mixing of nectar and some of pollen from different plants will produce different colors of honey. And if you compare honey from different types, and also in multiple regions, based on the different types of climates you'll see, will actually result in different ranges of honey colors due to the pollen and the nectar sources, the differences in each of these regions. So there are a lot of factors which actually determine the different types of colors which we see in honey. And based on the availability of these different plants, and also changes in each hive throughout the year, will mean that a single colony can change honey color in different stages throughout the year. So different colors also come according to seasons. So you'll be able to notice that also. Then Allah subhanahu wa ta'ala mentions fihi shifa'un linnas. Allah mentions that within this particular liquid there is a healing for people. This particular book by Munibur Rahman and Safiya Majid, who are editors of this book called Therapeutic Applications of Honey and its Phytochemicals, it's been published by Springer. it mentions very several uses of honey, and I'm going to just mention a few of them so that we appreciate. So we have wound healing, and under wound healing, honey has been shown scientifically to promote tissue regeneration, reduce inflammation, and prevent infection due to some of its antimicrobial properties. It's also used in burns treatment, just to reduce pain, accelerate healing, and also minimizes scarring in burns. It has been used as a cough and sore throat relief remedy. It actually acts as a natural emulsant and a cough suppressant. It soothes the irritated mucous membranes. It also has antimicrobial activity. It has been shown to be active against Staphylococcus aureus, E. coli, and various several types of microorganisms, even Pseudomonas aeruginosa, which makes it very ideal for patients with diabetic ulcers. So it has been shown to aid in healing diabetic foot ulcers and other chronic wounds. Honey is also very important in digestive health. It helps to relieve gastritis, inhibits H. pylori infection, and also improves the normal flora of the GIT. It has also been shown to improve sleep and helps to relieve anxiety in people. Honey stabilizes blood sugar levels and also helps to release melatonin. So if you're having trouble sleeping at night, you can decide and take a tablespoon of honey before going to sleep. And it also helps to reduce anxiety. So what are the contents of honey? I just want to share this because Allah subhanahu wa ta'ala mentions here that إِنَّ فِي ذَلِكَ لَآيَةً لِقَوْمٍ يَتَفَكَّرُونَ. We need to ponder and think and study what Allah mentions in the Quran. It mentions about this liquid. So what about this liquid? It has a lot of nutritional amounts. It has carbohydrates, it has proteins, it has fats, cholesterol, vitamins, and even minerals. And then we have other bee products which the bee produces, which also points towards this particular liquid, because Allah subhanahu wa ta'ala mentions that this is a liquid. It doesn't mention that this is honey which is being produced by that. It mentions that this is it's a liquid, and there are several types of other liquid products which are being produced by honeybees. So we have among them propolis, we have also royal jelly, we have bee pollen mixed with together with propolis and royal jelly by the honeybees. We have bee venom, we have bee bread, and we even have bee wax which is being produced by these honeybees. So if you look at propolis, it also has a very good medicinal values. It has been shown to be a good medicine for cold and sore throat relief. It has immune. It also has been shown to be good in wound healing and skin care. It also has antimicrobial effects. And under GI, it also has ulcer and gastritis relief properties. If you look at royal jelly, it has been shown to have good nutritional support. It's rich in proteins and minerals. There's also antioxidants. It helps to improve skin elasticity. It makes you look like you are still young, so it's good for the elderly to take this particular product. It has anti-inflammatory action, so it helps in immune support. And for those who have issues with fertility and reproductive health, it has also benefits on that particular part. And it also has been shown to reduce cholesterol levels, LDL. If you look at bee pollen, it has it's a mixture of actually flower pollen together with nectar and enzymes and some of this honey and bee secretions. And it has been shown to be an energy booster, good for skin health, helps in hormonal balances, and even weight management. It also has been shown to provide allergy relief. Then we have other products like bee venom and bee bread. All these are being studied for their anti-cancer properties. So I want to finish my presentation by mentioning that Allah subhanahu wa ta'ala mentions about this particular creature and shows that we get guidance from Allah, because this particular verse mentions that this particular creature operates under the guidance of Allah, and it follows a particular route so that they are able to identify these particular flowers where they are. They are able to fulfill their role in the ecosystem. Another message we get is purpose and productivity. Bees are a model of diligence, organization, and purpose. They produce this particular fluid, and this particular fluid, actually, Allah subhanahu wa ta'ala describes it as a source of healing for humanity, and it helps to broaden our lesson of contributing positively to the society as well. So if this particular creature is well organized and diligent and full of purpose, then it is a source of inspiration for also human beings to be the same. And then we have interdependence in creation. Bees play a crucial role in pollination. It showcases the interconnectedness of life and the balance Allah has established in nature. It helps us to reflect in gratitude and have gratitude. Allah subhanahu wa ta'ala invites us to reflect the wisdom of Allah's creation. So here we are able to appreciate Allah's creation, express the gratitude for the blessings. This particular creature produces all this liquid which has so much medicinal properties and benefits, and being simplicity and complexity. It serves as a reminder of the balance between simplicity and complexity in creation, where even a small creature like a bee can demonstrate intricate design and purpose. And lastly, bee as a pharmacist. It shows here bee actually produces medicine. So the question is, does it have a degree in bee farm? Thank you very much.
Thank you very much, for that wonderful presentation. Allah subhanahu wa ta'ala says, سنريهم آياتنا في الآفاق وفي أنفسهم حتى يتبين لهم أنه الحق. It's coming, slowly by slowly. The science that we are talking about. This is really very, very precious. Now, before I call our second speaker, I would like to recognize some very distinguished guests. Some of them have already introduced. The first one is Dr. Zainab Kura, Deputy Director from the Minister of Director General from the Minister of Health. Dr. Abdi, whom I already introduced from Shah, and also Professor Abdul Rashid, President of FEMA. Welcome. Professor Majid, who we introduced yesterday. And also for those of you who are not here yesterday. And then Dr. Abdel Nasser from Pharmacy and Poisons Board. And of course, other delegates from East Africa. Welcome, and we sincerely appreciate your presence. Now let's move to the next presenter. And we agreed that at the end of the day, we will bring all the presenters here, including, I hope, Dr. Yaqub will join us from wherever he is. We will ask questions. Allow me now to request our distinguished presenter next, Dr. Islam. I'm sure many of you are familiar with Dr. Islam. He's an educationist and Islamic leader and a researcher. It's a long list, but I will try my best. He was also the former Vice Chancellor of RAF, the current Islamic University of Kenya. And currently, he's involved in so many other things. He's the founder of the Al-Munawwar College. He has also designed and taught several courses in diploma and graduate and postgraduate levels, both in public and private university, including the UCAT, Technical University of Mombasa, Pwani University. He earned his master's and doctorate from International Islamic University in Malaysia, and bachelor's degree from Sharia, University of Imam Muhammad in Saudi Arabia. He's also studied from Al-Haajar We have a distinguished scholar. Welcome, Ustad. Assalamu alaikum.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على رسوله الكريم وعلى آله وصحبه أجمعين. أما بعد. I'm aware that most of you who have seen me elsewhere, other than this platform, you are used to seeing and hearing me speaking or communicating in Kiswahili language. That's the common language we normally use when we speak to the masses. But today, this being a technical forum that is bringing together a team of experts and learned people, I think the right language that we should maintain using is English language. So don't be scared to see me here wearing these kinds of kofia and speaking in English. And you start wondering what kind of are we seeing this guy is talking in English language. The topic I was assigned to talk about this morning with you is the concept of life and death in Islam. Now, initially, when I was looking at this topic, once it was assigned to me by our esteemed members of the organization, I thought it's going to be quite a brief topic that I'm going to dwell into and provide some highlights, and the job will be done. But when I researched this topic and presented it in a manner that will fit this particular setup, I came to discover and learn, first of all, myself, I benefited a lot. And I came to discover that it is indeed a very in-depth topic. It's a very comprehensive topic, a very important and significant topic that touches most areas of our lives, in particular, the ones by the sequence of the words. Okay, all right. That's quite okay. It's well understood. But we have other verses in the Quran that says or gives us the support to that point in a much clearer way. Okay. Like for example, if you read Surah Al-Baqarah, the beginning of the surah, Allah Azza wa Jalla says, كيف تكفرون بالله وكنتم أمواتا. How do you disbelieve in Allah when you are first dead? Then after your death, فأحياكم. And then He brings back again death to you. ثم يميتكم, then you die. ثم يحييكم, and then is going to bring you back to life again. So we have 2 deaths and we have 2 lives mentioned in this surah. We are going to talk about them later. Now, how do you move this slide? Oh, sorry. So the one? We are still in the old school, sorry?
Oh,
Which?
this one is the different one.
Oh, okay.
Yeah,
Okay.
this.
Oh, this one, yeah, all right. So my talk is going to cover 3 major areas of the topic. The first area is life and death, meaning and insights. The other one is types and components of life, and the third one is beginning and end of life. With the first topic, that is life and death, that is the meaning and insights, we are looking at such areas that are touching particularly the issue of the linguistic meaning of life and death, as well as the Quranic connotations of life and death. Okay, and then we'll move to types and components of life, and then we'll end our topic briefly with beginning and end of life. Now, if I may just mention some few areas or few aspects of the discussion. Now, if we start with the linguistic meaning of life and death, I'm starting my talk with death first of all, because as we agreed, death came first before life. Now, for us to have a comprehensive understanding of what life is and what death is, we need first of all to capture the comprehensive meaning of these 2 terms as used first in Arabic language, because these are Arabic terms, and secondly in the Quranic and Hadith perspective, because this is where these 2 terms are continuously being used and interchangeably also used against other terms, as we're going to see. Now, why is this important? It's because from the linguistic perspective, if we read the Holy Quran, you're going to discover that the word death, which is maut, and the person who is dead is referred to as mayit. Now, the Quran gives us an indication of the usage of this word under various connotations. Let's begin with some examples. We read from the Holy Quran, for example, Allah Azza wa Jalla says, يُحْيِي الْأَرْضَ بَعْدَ مَوْتِهَا. يُحْيِي الْأَرْضَ بَعْدَ مَوْتِهَا. Allah Azza wa Jalla brings back the land to life after its death. And then in another verse, Allah Azza wa Jalla says, in the words of Maryam, the mother of Isa alayhi salam, يَا لَيْتَنِي مِتُّ قَبْلَ هَذَا وَكُنْتُ نَسْيًا مَنْسِيًّا. In another verse, Allah Azza wa Jalla says, أَوَ مَنْ كَانَ مَيْتًا فَأَحْيَيْنَاهُ. Don't you see the one who was dead and then we gave him life? And in another verse, Allah Azza wa Jalla says, يَأْتِيهِ وَيَأْتِيهِ الْمَوْتُ مِنْ كُلِّ مَكَانٍ. So I've read 4 verses. In each of these 4 verses, the word maut or mayit was used. But in every verse, the meaning of maut and mayit is different. And this is what we mean by connotations. Okay, so let us engage. Let the talk be a little bit interactive, so that I'm not the only one who speaks, so that we are all engaged. So in the first verse, mayit or maut refers to, who can make a quick guess? فَأَحْيَا يُحْيِي الْأَرْضَ بَعْدَ مَوْتِهَا. The word death in this verse is used under what connotation? In a quick answer, who can briefly join me up?
Barren.
Sorry?
Barren.
Barren, great. So the word maut ba'da mautiha here refers to barren. Ya laytani mittu qabla hadha. What's the meaning of maut in this verse? Said by Maryam. Any guess? Because she was under pain. She said these words when she was under, what do you call that pain? Labor. Yeah, okay. So what is mouth in this context? Really? She wished to... Death itself, really? Any other? Not feeling the pain. The sense of losing, the state of losing sense to pain. All right? That's what has been translated by many scholars of tafsir. In the third verse, our man kana maitan, and the one who has been dead, فَأَحْيَيْنَا, and we brought him back to life. What's the meaning of dead in this verse? Huh? Hopelessness. Okay, something much better. Our man kana maitan, and the one who has been dead, فَأَحْيَيْنَا, and we brought him back to life. So death here means misguidance, exactly. Misguidance or being astray. And then Allah Azza wa Jalla guides him and he becomes alive. That's why he says after these words, فَأَحْيَيْنَاهُ وَجَعَلْنَا لَهُ نُورًا يَمْشِي بِهِ فِي النَّاسِ. In the last verse, يَأْتِيهِ الْمَوْتُ مِنْ كُلِّ مَكَانٍ, that refers to sorrow. That is, death comes to him, the one who is being punished in the torments of fire in the day of Qiyamah. He's going to see death coming to him from all angles and directions, but yet he's not dead. Okay, that's what means sorrow. Now we move on to the next part, that is now the Quranic connotations. That has all been linguistic only, linguistic connotations, even though we quoted verses from the Holy Quran. Now the next point to also look at, quite interesting, under the word meanings and under the word meaning before insights, we have now the Quranic connotations. If we look, for example, at the word, at the same verse that we read, our man kana maitan, the word mayit here means talal, and then Allah Azza wa Jalla says in another verse, فَسُقْنَاهُ, Allah Azza wa Jalla, when he sends the winds which carry clouds that contain water. Allah Azza wa Jalla talks about these winds by saying, فَسُقْنَاهُ إِلَى بَلَدٍ مَيِّتٍ. So he's carrying the clouds, using the winds, Allah Azza wa Jal, the wind carry the clouds, ila baladin mayyit, to a land that's barren, that has been given. And then the verse, amwatun ghayru ahya, that's another connotation of the Quran. By using the word dead, it refers to something that is not living. Non-living thing is also referred to as dead, because Allah was talking about idols that were worshipped by the non-believers, and he called these idols as amwatun ghayru ahya. They are dead, and they could not be alive to respond or to hear what prayers are being made to them. Finally, we also have another new meaning introduced by the word death. New meaning of the word death introduced by the Holy Quran as a connotation, and that refers to disbelief. Allah Azza wa Jalla says, يُخْرِجُ الْحَيَّ مِنَ الْمَيِّتِ وَيُخْرِجُ الْمَيِّتَ مِنَ الْحَيِّ. This verse was interpreted in two ways by the scholars. The first one is the one that is quite familiar to most of us. That is a scientific way of interpreting it. That's where Allah Azza wa Jal brings out something that is dead from something that is alive, and brings out something that is alive from something that is dead. The other interpretation is Allah Azza wa Jalla gives birth to a Muslim from parents who are non-Muslims, non-believers, and gives birth to children or offspring who are non-believers from parents who are believers. That's another interpretation of life and death in the Quran. Now, very quickly again, if we move to the next slide, we're going to see the Quranic insights. The Quranic insights about life and death. I'm going to go through this very quickly because of time limitation. The Quran, the Holy Quran and the Sunnah of the Prophet ﷺ gives us some insights, implications of life and death, and how we are supposed to look at death as a concept and as a belief to be accepted. The first one is the fact that death, as mentioned by my brother here when he quoted the verse, تبارك الذي بيده الملك وهو على كل شيء قدير الذي خلق الموت. That's where we have the first insight, that death is a creation of Allah. The same way you and I are a creation of Allah, death itself, by itself, is also a creation of God, Allah subhanahu wa ta'ala. That's why he said, خَلَقَ الْمَوْتِ. So death was created, and it is a creature of Allah subhanahu wa ta'ala. Next is that death is inevitable. Every living creature is going to test death. The third one is that death is timed, is predetermined by Allah subhanahu wa ta'ala with an exact timing. And the next one is that death is strictly known to Allah subhanahu wa ta'ala. That's why we say it's a divine secret. It's only known to Allah azza wa jal. Nobody knows when he or she is going to die, where he or she is going to die, and how, and so on and so forth. This is why Allah azza wa jal says in the Holy Quran, وَمَا تَدْرِي نَفْسٌ مَاذَا تَكْسِبُ غَدًا وَمَا تَدْرِي نَفْسٌ بِأَيِّ أَرْضٍ تَمُوتُ. Now, next one is, when we are still talking about death very quickly, we have categories of death. Now, death in Islamic jurisprudence, that is fiqh, is not looked at as one aspect or from one dimension. Normally, scholars categorize death into three categories. The first category of death is actual death. And this is where someone dies and is declared dead under the normal circumstances that happen. The second category is called legal death. Now, legal death is death that did not actually happen. We are not sure that it has actually happened, but we tend to be convinced that this death has happened. And this is strictly applicable in fiqh in an occasion where a husband, for example, disappears for some time. There are no whereabouts about this person for 2 years, 3 years, 5 years, 10 years. We don't know where he's gone. The wife is there stranded. She is hanging. She's not sure whether she's still married to this guy or not. Now, if she brings her case forth to the Qadi is going to take a legal judgment to pronounce the death of this husband, even though the death is not actual. It has not actually happened. But after the lapse of 4 years, according to the madhab of Jumhur, when 4 years lapse, and we have no whereabouts of this husband, where has he gone? We don't know. You have any information? Anybody with information about this guy? Nobody knows. So the Qadi is going to declare the death of the husband and will tell the wife, you are going to stay for iddah of death iddah, that is 4 months and 10 days. After which, you are now going to be free to be married to another person. Okay? Don't ask me after this what will happen if the guy comes back. That's going to be something else. Okay? And now finally is al-maut taqdiri, presumed. Now, presumed death is quite technical in fiqh, and this is where this applies to almost three madhahib: madhab Hanafi, Maliki, and Shafi'i. Presumed death is strictly happening with the fetus, the embryo. Now, if a pregnant woman is assaulted, physically assaulted with violence, and she's pregnant, and she's carrying in her womb an embryo that has not yet been alive. Okay? So, if she miscarriages, okay, that violence leads to miscarriage, then scholars will presume that that particular fetus, the embryo, was alive before its death. And therefore, the offender is going to be made responsible for the death of that particular fetus. And this kind of death in fiqh is known as presumed death, known in Arabic as al-mautu al-taqdiri. So we have al-mautu al-haqiqi, actual, al-mautu al-hukmi, which is legal, al-mautu al-taqdiri, which is presumed. Now, I can see I'm almost out of time allocated to me. Now, we have not even touched about life. Okay? All right. So I'm going to stay with the death. I don't know. Okay, anyway. I was having in my mind that by any means I'm not able to go through this topic. It's a very lengthy topic, as I said earlier when I was making the introduction. And for this reason, I thought the best way to share this knowledge and information with members present is to put it in a research paper. Okay, to put it in a research paper, which I have converted it into a whole booklet that comes to about 52 pages in Arabic language, which I later translated into English fully, that has come to about 39 pages. So this book in 2 languages, 2 versions, Arabic and English, they are both ready, available. Inshallah, I'm going to share with you once I am after the talk. Okay, there's a lot to be discussed. Now, if you will allow me, just in 1 minute, through the technical team, we're keeping time. The reason why we are talking about life and death in medical practice is because of the implications of these 2 concepts. Concept of life, concept of death. The concept of life engages the medical practice in many scenarios. One of them being how, where, and when do we take a decision to remove the life of an embryo or a fetus. That is with regard to life. When it comes to death, the matter is even more complicated. This is now with regard to how and when and what makes the medical practitioner to take a decision of declaring that the patient is dead. When is the patient considered dead in under jurisprudential perspective? And why this is important is the fact that in medical practice there is this common notion or understanding that when a person is dead via the cessation of breathing has stopped, the organ failure, complete organ failure of the body, nothing functions in the body, and breathing has stopped completely, irreversible, then the person is declared dead. That is according to classical medicine. Now, in recent years, something new has cropped up, and that is what is known to medical practice as the death of the brain death in short. Okay, the brain death. Now, can a doctor, a Muslim doctor, consider a patient whose brain has died as being dead in Islam? Because the brain has died. Okay. Now, this leads us to another very important aspect again in fiqh, and that is concerning this particular patient is under assistance of the medical apparatus, medical equipment, breathing, and all mechanical equipment that you normally put on these patients to breathe and so on. Okay. Now, if you remove these devices, the patient is going to die. You decide to let them stay, but the brain has gone. Now, this apparatus, this equipment, is helping the patient to, let's say, to breathe, some body organs to function, such as the heart and so on. Now, will that doctor be held liable in fiqh of death if he is going to decide to remove the devices, judging from the fact that the brain has died? Now, is brain death considered death in Islam under fiqh perspective, under fiqh consideration, or not? That is a very important aspect that I really wanted to go through, but due to the 20-minute session limitation, I was not able to cover. I didn't even talk about life. I didn't talk about anything. So this was just only, I think, an introduction. So I don't know. I'm going to be left with this, aspect for you to ponder, and then, inshallah, I'll be forced to stop here because of time factor. Shukran, jazakumullah khairan. Assalamu alaikum wa rahmatullah.
Alaikum salam wa rahmatullahi wa barakatuh. Shukran, Ustad. Sorry for the time factor, but I hope during the discussions you are able to elaborate more time. I know we are supposed to go for tea, and people are really anxious to go have a cup of tea or a break. But before that, we have one last presentation from our sister, Dr. Saad Abdallah, I'm told her presentation is very short. Saad Abdullah holds a master's MPH from Johns Hopkins University and a first degree in medicine from Nairobi University. She has worked in many, if I read this list, you'll take it. And she has worked in the, World Health and the other United Nations, Global Fund, and Ministries of Health in various places, Red Cross and Red Crescent, for over 20 years. Karibu Daktari. Thank you.
Assalamu alaikum. Assalamu alaikum wa rahmatullah. I wonder, Professor Almarhum Professor Muhammad Haidar said, when you wonder at a wonder, those are two wonders, all right? And today these sessions are, I don't know how many. And I hope that I'm really humbled after Dr. Islam to talk. I hope I will be able to hold your audience the same way. Okay, so I'm reviewing the state of Muslim health. This is a follow-up of my presentation last year. All right, so the outline is this, that basically we will look at all the studies that have been done that look at religion, looking at these different categories of people, and including key populations. Yeah, so, because of time. We first need to know who are Muslims, because that is the biggest challenge here. We are labeled as 5.6 million, and whether we really agree on this, and the Somalis being the largest group. So we need to look at the history of Muslims. Are we really 5.6 million if we've been along the coast since like the 7th century? All right, so we have Muslims who came from the Arab world, initially 7th to 10th, then 13th through 15th century, from Syria, Iran, Oman. Then we have Asians who came in the, to build the railway. And these were the Baluchis, Ismailis, Ithnashari, Bohra. So when you're told they are 45,000, and they've been here, over 100 years. And then after the railway, then more Indians came, economic migration, all right? And then the Arabs mainly stayed at the coastline, but then as the railway built, they moved inland. And as they moved inland, they were now Kericho, Kakamega. So we have these Muslims from that over 100 years. And yet, when you look at the population estimates for these other locations, they'll tell you maybe 1,000. So we are looking at, let's see, this thing is going. Yeah, so last year I talked about, searching any studies that said Muslim or Kenya Muslim or health and Muslim or Islam and health or, and I was mainly looking at disparities. Sometimes it's Somalian health or Swahilian health or Asian in health. And my biggest challenge is Asian in health. I just cannot find it. I hope Dr. Qureshi, you might be able to help. So the papers that had anything to do with religion, or they talked about Somalis or Swahilis or Arabs or Nubis are the ones I reviewed, okay? So what I found is that majority were looking at women. Yeah, women are the most studied population. And then we have some on children, but the men, you just can't find on Muslim men. I don't know why. So what do we know about Muslim children? Even though there are studies, but the studies don't say Muslim or Islam. They just talk about children in general. So when you look at studies on Northeastern, then you assume that these are Muslims, right? But we know in the coast, it's a very mixed cocktail of people. Yeah, so, but we do know that what the studies say is that the immunization is not where it should be in the Muslim world, or the population. So there is under-vaccination, incomplete vaccination. There is also low birth weight. Yesterday there were a presentation about low birth weight. Then we also they mentioned about breastfeeding, that Muslims do breastfeed exclusively. Or some, it's longer, but not necessarily exclusively. Then Wasingishu, we do get to hear that they're orphans who are Muslims. Or Pokot, they are Muslims. So, or that we do have in Mumias children who got HIV through mother-to-child transmission, and they say that risk factors are premarital sex or drugs and all that. So what do we know about adolescents when we look at adolescents? Adolescents, it's risky behaviors. So we see Somalis, Coast, Nairobi, all of them, this is where they are, they are attracted to. And like in Mombasa, we are seeing that it is living in urban areas, having a monthly allowance, attending mosques irregularly that predisposes the adolescent boys to drug use, right? And then we do see, like in Nairobi, they had a slum survey. And so in the slums, they actually identified Muslims living in the slums. And there, you're giving me 3 minutes. Huh? No, I refuse. No. We do see that they support the community. Like Mombasa, they had a study on adolescents in high schools, and the adolescent girls just said that our community, our families, they don't support sexual and reproductive health care for us. And the parents, the study said that they don't talk to their children about sex, family planning. It's like, no, that's taboo. You should not be knowing these things. Or they push their responsibility to teachers. And teachers, they don't have the dean in their curriculum. It's just they're told by the education ministry, this is what they need to know, and that's it. Yeah, and so even the study was offering STI screening to the girls, and the parents said, we only consent if you tell us the result. And even the teachers would not support unless if the parent had consented for the girls to get STI screening. All right, so other studies have looked at mental health for adolescents and seen that they have less depression compared to non-Muslims. So then we do have a study on Muslims who are living with HIV, young Muslims living with HIV. And they were using a mobile kind of messaging. And these adolescents really, really appreciated spiritual messages because it gave them hope, right? So even Kakamega, we had the Muslims adolescents who were living with HIV. So all these are people who, need support, yeah? So when we look at FGM, let's see. This one, just in the graphs, it shows like the many disparities. We're all Muslims, but when you look at the situation, compare northeastern Muslims vis-a-vis coastal Muslims, we are very different. The access to sanitation, Wajir is the west. Education, northeastern was very poor. So why are we surprised when there are disparities in health outcomes, indicators? So, yeah, when we look at FGM, this one is the first bar is Kenya, the second bar from the left is Somalis. So we do see that they are very different. There are many variations of FGM. I don't know how well you can see, yeah? So the first one shows the age of when FGM occurs. So for Somalis, you have from even below 5 years, the girls are getting circumcised. Majority is now between 5 and 14, 10 to 14. Below is which communities rely on traditional medical practitioners to circumcise. Somalis, it's primarily traditional. Then those who, women who experience the types of circumcision, the top right, it shows that 27% of the Somali FGM is that they are cut and sewn. The others is they are cut with flesh, or some is just cut, you know. And then whether they believe that, the last on the right is what's the prevalence of people who support FGM, and you see 87% of Somalis, male and female, really support FGM to continue. Even though now the law, I think it's 2016, banned it, but the support is still very much there. So let's see. I think here I'll skip. But basically what they're saying is other communities have really cut down on FGM, except for the Somalis. It's like 11% used to oppose, 17% used to oppose now. It's like 11% used to oppose. Among the Somalis now it's 17%. Whereas the other communities, you see, up to 90% oppose. So it's a practice that is likely to prevail for some time. What do you know about the women? We've looked at adolescents, now we're looking at women. So women, we're looking primarily at ANC, prenatal care, and then skilled deliveries in hospitals. And we just see that among Somalis, even at the coast, there is low FP, low contraception, low uptake of skilled attendants, and the reason that they're giving is they just don't like to have male attendants. You know, it's that higher that we heard yesterday from Dr. Amin that is deterring Muslim women from delivering in hospitals. In the coast is that they just don't like all these frequent vaginal examinations, or they don't like that they are being pushed to take family planning after delivery. So for that reason, they avoid delivering, or there's low uptake, all right? Then that we do have postpartum depression among Muslims, and also infertility is something that's a taboo subject among Muslims. Women, when they have it, they don't talk about it, or they tend to say, it's qadr. Because of qadr, they don't want to consider interventions, alternatives, even if it is adoption. All right. This one I'll skip because of time. So Muslim men, it's like there's mental disorders. Then like in Wajir, they like big families till today. And women, it's like anything to do with health, the man makes the decision, all right? Health insurance, there's low uptake among Muslims, all right? Then there's cancers, like in Somalis, it's esophageal, breast cancer, non-Hodgkin's, okay? So I'll go to, I think, let's see, key populations, because I think this is a forum that we really, as a group, need to think about where we're going with them. Because we know that drug use is very prevalent along the coast. Sex work is also, Mombasa is a hotspot. It's like that's where you have the highest HIV prevalence. And whereas other parts of the country, maybe it's general population, but here the key populations are really fueling the epidemic. And then we look, I mean, the LGBTQI, it's there. And what we see is like half of the male sex workers who sell sex to men are Muslims. Or, 62% of men who have sex with men, they might be Muslims, Mombasa or Coast, that's where more than 50% are Muslims, whether you're looking at sex workers, people who use drugs, or MSMs, or those who sell sex to men. And even in prison, they admit that there is forced and consensual sex between men. So let's see. In summary, what we know is that the health access for these populations has evolved. Before, you couldn't find them, they were hiding, they wouldn't even go to hospitals or society. But now, it's like they've been empowered. And even now, before you'd say people who use drugs, people who use drugs. But when they need drugs, they engage in sex, they sell sex. And the sex workers, the men who have sex with men, that's what they do, is the sex, but now they use drugs either to cope or to help them perform better. So, and then these networks are just mingling. Yeah, they know each other. So what we are seeing is that there are studies that confirm that they show how HIV has moved from MSMs from Coast to Nyanza, as far as Nyanza. This is the transmission point, all right? And then the thing is, Mombasa is like very popular. Young people who are getting into these behaviors, they flock into Mombasa. And then when now they've made it and all that, then they move. So the young populations who are key populations are just a big problem. So basically we are saying we're a substantive population and we are increasing over time. And this is because of poverty, peer pressure, idleness, and all that. And you know, that the other issue of concern is that the Muslim men and women engaging in anal sex, even though religion forbids, but there's high prevalence of that. And we find that the men who engage in male-to-male sex, they are married. Half of them have children. 69% have a wife. But they're doing this and, you know, so it's just crazy. And then you'll hear of drop-in centers that support men who have sex with men. The community protests and they get closed. But what they do, they go virtual. So now we find that more of them are recruiting clients virtually. And who are they recruiting? Students, you know. So it's just, you know, very scary. So you find before it was physical, they would go in the streets and look for clients. Now half do streets, half do mobile phone, but there are those who it's purely virtual. Yeah, they just recruit virtual, and these are the more well-off men who have sex with men recruiting boys. So social media, yesterday we also heard that it is helping the people to learn more about how stimulants, mogoka, increases their sexual performance. So in conclusion, this review has just dispelled the myths that Muslims don't take alcohol, Muslims don't engage in anal sex, and that FGM prevents promiscuity. Because we did find migrant workers from Somalia who have had 46% have had FGM, but they're selling sex because of poverty. They just had no other means of livelihood. So the studies there's a lot of bias on women, children, adolescents, but also on key populations. So we do see that in terms of health status, Muslims, they are gaps with regards to MNCH, and that some religious practice beliefs are hampering the Muslim women from accessing health services. Okay, so, but we appreciate that religion is, to some extent, is helping people to cope with mental health, and even there's less prevalence of intimate partner violence or GBV reported among Muslims compared to other faiths. Yeah, so we do need to show at least more support for some of these needs, these populations. So yesterday, Dr. Amin said there is about Muslim identity, then there is modesty, there is what else did you talk about? Yeah, there is qadr and there is prayer. Yeah, so we do need a lot more studies to be able to show the positives of these Islamic values in helping people access healthcare. Dr. Fatma talked about equity. It is our responsibility to assure equity for our people. So how can we do that? Yeah. Can we also look at we're looking at Muslim, but Muslim is an identity. Are we looking at the frequency of prayers, frequency of fasting, those frequency of engaging with, imams and all, to what extent that influences health? Yeah, because I've been looking at even the talks on diabetes. There's a study, you look at diabetes, studies since 2000 till 2020. No study of that period looked at Islam. We're talking about Ramadan and diabetes. Why are we not talking about how many of our Muslims in Kenya are diabetic? Yesterday we had a talk on preterm or low birth weight. But we're not looking at the contribution of the prevalence of low birth weight in Muslims, right? And that fasting does, if you fast in the first trimester, the child could end up having low birth weight, right? We're not looking at that. We're just reporting on our outcomes without looking at the Islamic lens, okay? So our recommendations is let's have a more strategic research agenda, okay? We need to also look at the men and the boys. These are so vulnerable. So I hope, I think I've talked about the other things, but the other thing is to what extent are we or our clients discriminated based on their Muslim identity? We really need to look at that, because we just assume that everybody's treated the same. Is that true? All right, and then for me, I started with the population estimates. I would prefer we start counting how many mosques we have in a place and use those mosques to determine how many families, households, and get a better understanding of our people. And use the mosques to identify who are the people who are living with HIV, who are the people who have other health needs that can be better supported through us, all right? But my last appeal is to all the practicing health practitioners who are Muslims. As a minimum, last year I begged, add religion to your health statistics. Because to me it's substandard care if you cannot report on the number of Muslim patients you are handling. All right?
Thank you very much, Dr. Sada, for that wonderful presentation. We sincerely share your concept and your concerns, particularly the population and the other factors that really need to be unearthed. Because of time factor, I'm afraid we might not be able to have the questions and answers at the moment because we have started for quite a long time. And may I ask Dr. Maalim now to take over and guide us in the next session.
Assalamu alaikum wa rahmatullahi wa barakatuh. Takbir. We've had an excellent sessions from excellent speakers. I take this opportunity to thank all the speakers, Dr. Islam, Dr. Rilwan, Dr. Fatma Abdullah, Dr. Saade, and Dr. Yaqub, and without forgetting our psychiatrist, Dr. Rajab Saddam. So we've come to the end of the morning session. We are a little bit behind schedule. Now we'll go for a tea break. We'll take around 25 minutes. Okay, we should be here by 11:25. For now, the biggest occasion, that is the opening ceremony. We have our dignitaries already in the room, and we'll want to hear after the opening ceremony. We have a great panel led by Dr. Abdullah Bajabir, where he will take us through a great topic, inshallah. So housekeeping, so the tea will be at the expo center. And we urge you just to take your tea and also visit the booths. It's important. There's also a surprise gift for people who will visit all booths. So the first booth is actually the Kammp booth. There'll be a paper whereby you take from the Kammp booth and you make sure that paper is signed by every single booth for day 1 and day 2. And we are actually going to announce 3 winners at our great gala dinner. That will be today at 6:30 by the beach, inshallah. I will urge you all not to miss because it's a great networking opportunity. So without much ado, I would like to, we be back here by 11:25, inshallah. Visit the booths and also stand by the poster, inshallah. Subhanak Allahumma bihamdik, ashhadu an la ilaha illa ant, nastaghfiruka wa natubu ilayk.